On the topic of interventional physiatry, may we start the next session on recent advances in PMR interventions, to be taken by Professor Dr. Sanjay Kumar Pandey, the professor and head of the Department of PMR in AIIMS Patna. And may I please call upon Dr. S.P. Sinha to kindly chair the session. Dr. Pandey has started with one person in the Department of PMR, and now they have their own building with their own parking lot. I said, how cool is that? You have your own dedicated parking lot in the hospital.
Thank you, Dr. Kostu. Thanks, organizer, respected chair, delegate and audience. So actually recent advances in PMR. So what is exactly recent and how much recent is the recent? And before going to the recent, should I talk about the ancient? Before going to recent, I must talk about something about the ancient. So not going very long back, when I joined this PMR department, during my this Kolkata PG entrance examination, I got actually rank was not so good, only 56. So I wanted to have this degree in medicine, but I didn't get that chance. So someone told me, you can opt for this PMR. So even in my PMR days, when I opt for PMR, I was not aware about the PMR speciality myself. And during our training days, we were used to prescribe these exercises and many things. So in our country, the 4 pillars of this medical care, that is preventive, promotive, curative and rehabilitative. So you can see the jump from the ancient to recent. Now, even the WHO has decided its theme, that is the rehab for all by 2030. So WHO is talking about rehabilitation. The NMC is talking about rehabilitation. Out of 706 medical colleges, now we have more than 185 medical colleges which have PMR department. And the PG seats in India has already crossed almost 150, nearing by 150. So there are so many aspects of recent advances in PMR department. Now I just only talking about this awareness and in medical education field and the awareness among speciality, inter-speciality and the PMR specialist particularly. So many things has been advanced from my PG days to this today. So if I took this 3 years advances, that is characterized by the integration of advanced technologies, personalized care approach and expanded access through tele-rehabilitation. And these are 3 trends and innovations that we can say advances. That is the shifting towards integrated, technology-enabled, system-level solution that support personalized recovery across condition and ages. We are discussing here this critical care rehab, pediatric rehab, this rheumatological rehab. So we can see here the scope and advancement the PMR has made across the specialty by innovation and combining the digital tools, assistive robotics and procedural intervention, and combining with traditional rehabilitation. Don't forget that traditional rehabilitation, they still are the best and we cannot just undermine them due to the recent advances. And again, the intensity of the therapy that has been added up by the introduction of these tools in the rehabilitations. What are these tools? These are the wearable sensors and artificial intelligence. Now we all are having our smart watches in our wrist. And what these smart watches are telling us, how active you are, how much calorie you have burned, and everything. And also it providing biofeedback so that you can set your target based on your requirement, your need and your rehabilitation. And these same things can be applied to the patients which are admitted for rehabilitation by using of this technology. Now robotic expansion. You can see this robotics rehabilitation, the locomat, the exoskeleton based gait training. Everywhere this is incorporated setup. Now the government is also acquiring it at various setup. Now interventional integration. There are many targeted procedural with active rehabilitation are emerging to accelerate pain relief. PRP we know, barbotage, this guided nerve blocks and everything. Rehabilitation remains essential alongside disease modifying treatment to manage function. We have rheumatologists among us, they can very well tell about this disease modifying drugs. And if we add it up with the rehabilitation, obviously the outcome will be much more better in terms of patient care. A strengthening health system through tele-rehabilitation, because each and every patient coming from far-flung area cannot come to your department during the follow-up. So by actively adopting these tele-rehabilitation methods, we can provide them at their home the rehabilitation setup. There are few novel therapeutic approaches, like rehabilitation remains central for children receiving novel disease-modifying drugs, especially for children with muscular dystrophy. The child with muscular dystrophy and this, you can very well, we all are aware about this parental emotional burnout and the physiatrist burnout with the child with muscular dystrophy. Here this novel therapeutic approach can be helpful to them. Again, interventional rehabilitation cases, combining this with ultrasound guided procedures, which I already told. The regenerative therapy and orthobiologics, this PRP and stem cells. Stem cell we are not using, being a government institute, we need to follow the protocols. But this PRP we are using in many conditions and gaining excellent results, even in pressure ulcer injury, the non-healing ulcers and other kind of things. PRP is helping us. Now robotics and human-robot interaction, from even pediatric to geriatric, the gait training to stroke recovery, from TBI to SCI. Everywhere this robotic based gait training is very important and it is helping us out in gaining functional gain in patient recovery in these chronic conditions. These are powered exoskeleton, wearable AI, and clinical tip is integrate exoskeleton session with physiotherapy goal. That is intensity task specific practice. So if you have good physiotherapy setup at your place and you have fortunate enough to having a PMR specialist there, then goal-based, target-oriented, intensive session with this exoskeleton and robotic training can be implemented at your setup. Virtual reality, augmented reality, already been talked about. Now, neurological rehabilitation in pediatrics, because we are talking about this TBI in adult, but again in pediatric patient, the consensus recommendation for early TBI evaluation emphasizes this multidisciplinary approach that spans pediatric and calls for optimized rehabilitation pathway and outcome measurement in children. Even the scale of assessment and rehabilitation technology, the methodology, both are different in pediatric cases with TBI. These are neurostimulation technique, this RTMS, transcranial direct cranial stimulation, and this non-invasive devices like ARC-X, showing clinically meaningful upper limb improvement in tetraplegia patient. So even SCI patient, when there was no hope of this neurological recovery, this magnetic stimulation, this neurostimulation, this invasive stimulation are producing good result in the form of functional recovery. Rehabilitation remains the cornerstone to manage evolving phenotype as children with neuromuscular disorder live longer due to new therapeutics. Even the gene excision therapy has come into play for the children with DMD. Musculoskeletal and developmental condition, the assessment advances has been made by the imaging and body composition tools, which are increasingly used to characterize pediatric obesity and muscle deficit that affect our rehabilitation planning. Now the functional classification adoption, this GMFCS, IFC, everything is there to classify classify a disease and a patient in a universal way. So your classification, your diagnosis, your functional this goes across this country and this locality. It will be everywhere same. So I will must come to this key advances, 2 slides. Technology-enabled personalization through AI and wearable sensors. The expanded access via tele-rehabilitation platform, enhanced engagement through VR and gaming, intensive practice supported by robotic system. And what are the limitations here? The heterogeneous protocol, variable quality of evidence in some area, long-term outcome include cost effectiveness, and recommendations are enroll eligible patient in trials and contribute to registries when possible. So to conclude, the period from 2022 to 25 marks a pivotal transition in PMR characterized by the convergence of advanced technology with traditional therapeutic approach across pediatric, adult and geriatric population. Innovation in robotics, artificial intelligence, virtual reality, tele-rehabilitation are expanding the reach, intensity and personalization of rehabilitation services. So these are my take-home message and these are my references. Thank you.
Thank you, Dr. Pandey. ডক্টর পান্ডে নেমে যাওয়ার আগে আমার একটা কথা বলার ইচ্ছে হলো। ওর কথা শুনতে শুনতে আমার 1983 সালের ফেব্রুয়ারি মার্চের কথা মনে পড়ছে। ওই সময়ে আমি পিজিতে ফিজিক্যাল মেডিসিন ডিপার্টমেন্টে হাউস স্টাফশিপ করতে ঢুকেছি, আর তখনকার আমার সঙ্গী এখানে বসে আছে ডক্টর বিকে চৌধুরী। তো আমি হেড অফ দ্য ডিপার্টমেন্ট উল্টো দিকে চেয়ারে বসতাম, যারা উপরে গেছে তারা ঢুকে দেখেছে, দরজা দিয়ে ঢুকেই ডান দিকে আমার বসার চেয়ার ছিল। তো কি করতাম, আজকে এটা খুব রেলিভেন্ট বলাটা আমার মনে পড়ছে বলে বলছি, তাহলে বোঝা যাবে যে সঞ্জয় কী নিয়ে কথা বলছে। সেটা হচ্ছে অর্থোপেডিক্স থেকে পেশেন্টরা ড্রেনড আউট হয়ে আসতো, ঘাড়ে ব্যথা আল্ট্রাসাউন্ড দিতে হয়, কোমরে ব্যথা শর্ট ওয়েভ ডায়াথার্মি, আর হাঁটুতে ব্যথা হলে ওয়াক্স বাথ, সেখানে কাজ শেষ, আর কিছু দেখতে নেই, শুধু এইগুলো করতে হয়। এবং তারপর অ্যাডিশনাল মজা হচ্ছে শর্ট ওয়েভ যখন বন্ধ হয়ে যেত, খারাপ হয়ে যেত, তখন নিচতলা থেকে ফিজিওথেরাপিস্টটা উপরে এসে বলতো, শুনুন ডক্টর সিনহা, এখন আর শর্ট ওয়েভটা লিখবেন না, যেখানে শর্ট ওয়েভ লিখতে হয় সেখানে আল্ট্রাসাউন্ডটা লিখবেন, আল্ট্রাসাউন্ডটা ঠিক আছে, শর্ট ওয়েভটা খারাপ আছে। তো দিস ওয়াজ দোজ ডেজ। ডক্টর চৌধুরী বসে বসে হাসছে, নিশ্চয়ই মনে পড়ছে এতদিন পরে। এই জন্যে আলাদা করে উই আর এনরিচড বাই হোয়াট ডক্টর সঞ্জয় পান্ডে হ্যাজ টোল্ড। মেনি থ্যাঙ্কস।
Actually, credit goes to our youngster, and obviously the subject was initiated by such people. So now we are talking about AR, VR and everything, AI including everything. Now the PMR is everywhere. This intervention with surgical rehabilitation, with community rehabilitation, inclusive rehabilitation. The famous line of Kostu was during his PGT, rehabilitation means re-ablement to resettlement. Kostu was even not settled at that time by making the patient re-abled. He always believed in making them resettle in the community by making them integrated to the community. So it's a joint effort by everyone. I mean, we are so proud of our subject, and actually I feel very proud and very privileged and very lucky to I am in PMR. So thank you so much.